The chapter under examination discusses the challenges of the revised opt-out system and the secondary use of health data in England, focusing on the behavioral law and economics literature, particularly the nudge theory. It highlights the importance of understanding the psychological traits of human behavior and a variety of other factors such as emotional, social, and cognitive as the overarching framework to discuss legal issues. The UK government has established the care.data programme in 2013, aiming to build a central nationwide database for research and policy planning. However, the processing of personal data was planned without proper public engagement, leading to concerns about data protection and privacy. In May 2018, the government launched the National Data Opt-out (ND Opt-out) system, which is designed to regain public trust. However, there are no significant changes in the ND opt-out compared to the previous opt-out system, neither in the use of secondary data nor in the choices that patients can make. The chapter also explores the behavioral law and economics literature, particularly the nudge theory, which suggests that default rules are very powerful because people tend to stick to the default choices made readily available to them. The crucial question analyzed in this chapter is whether it is desirable for the UK government to stop promoting the Type 1 opt-outs, and whether this could be seen as a kind of hard paternalism. Section 6 delves into the theoretical discourse of libertarian paternalism in Cass Sunstein's narrative. Sunstein distinguishes between hard and soft paternalism, advocating for the latter, which provides freedom of choice. Behavioral law and economics, popularized by Richard Thaler and Cass Sunstein, postulates that improved choices and information disclosure can softly nudge individuals to improve decision-making and welfare. Examples of nudges include urinals with images of a fly to reduce spillage and cafeteria managers arranging food to encourage healthier options. Research has demonstrated that subtle design changes, such as default settings, can significantly impact behavior and conservation efforts. For instance, Rutgers University's switch to double-sided printing resulted in a 44% reduction in paper usage. Similarly, behavioral economics insights have been applied to organ donation, with opt-out systems leading to higher donation rates compared to opt-in systems. Empirical studies suggest that cultural and social factors influence decision-making in these systems. In the context of public health, behavioral economics can be applied to cancer screening. Linking cancer screening to familiar tests, such as dental checkups or annual vehicle testing, can increase participation. This approach leverages the power of nudging and default rules to improve healthcare outcomes. The National Health Service, NHS, in England provides universal and free public health services, generating a vast resource of primary and secondary healthcare data. However, the care.data program, initiated in 2013, was criticized for lacking proper public engagement and was ultimately cancelled. The National Data Guardian, NDG, developed models for consent and opt-out for the care.data program, leading to the introduction of a new National Data Opt-out (ND Opt-out) system in 2018. This system aims to facilitate the secondary use of confidential health data without explicit consent while respecting patients' autonomy. However, opt-outs can pose challenges to data integrity, and nudging techniques may be employed to minimize this risk. The UK government has emphasized the value of secondary health data use for research and policy planning, but public dissatisfaction with certain deals has raised concerns about sensitive data processing. Figure 1 illustrates the old opt-out system in England, which has been replaced by the ND opt-out system. Research suggests that there has been no significant change in the secondary use of health data, nor in the choices available to patients. Limitations and concerns regarding the opt-out system and data protection remain, highlighting the need for ongoing evaluation and improvement. In the context of healthcare data sharing, the Type 1 opt-out is the sole option that effectively prevents data from being shared outside direct care, as depicted in Figure 1. In contrast, the Type 2 opt-out, which was initially promoted, had unclear limitations, including the exemption of pseudonymized data for secondary purposes, regardless of patient choice. This was done to reduce healthcare costs and improve the system's effectiveness, thereby nudging patients toward the Type 2 opt-out, which was deemed to be in the public interest. The Type 2 opt-out has since been replaced by the National Data Opt-out, ND Opt-out, with existing Type 2 opt-outs automatically converted to ND opt-outs. However, the Type 1 opt-out is not publicly promoted, and can only be found on the NHS website under Resources for Health and Care Staff. The ND opt-out only applies when identifiable data is shared for research and managing the healthcare system efficiently, thus excluding anonymized and pseudonymized data. The terms anonymization and pseudonymization are used consistently with the General Data Protection Regulation (GDPR) and the EU Data Protection Board, where anonymized data cannot lead to the identification of the data subject, and pseudonymization reduces the linkability of a dataset with the original data subject. The National Health Service (NHS) utilizes various information materials to communicate the secondary use of health data to citizens, emphasizing its importance for research and policy planning. However, these materials may lead patients to assume that opting out is not necessary, as they do not explicitly convey the potential risks and consequences of data sharing. The materials also claim that strict rules about data usage were strengthened in May 2018, but this statement is debatable, given that exemptions to the opt-out system remain unchanged. The National Health Service (NHS) employs various strategies to inform citizens about the National Data Opt-out (ND opt-out) system, which allows individuals to opt out of sharing their confidential patient information for research and planning purposes. The provision of information materials, including leaflets and online resources, aims to educate citizens about the opt-out system and the implications of their choices. However, research suggests that citizens often lack deep knowledge about how their information is processed, and reading through privacy policies can be burdensome. The NHS provides special information materials for minority groups and young people, which differ in design and wording from the general materials. These materials are approximately 450,500 words in length and have a similar structure, with the leaflet for young people having a shorter general word length, making it easier to understand. The NHS regularly releases statistics on opt-outs, showing that the number of Type 2 opt-outs was 1.4 million in March 2018. Representing 2.42% of the population, and increasing to 1.6 million in March 2019, representing 2.74% of the population of England. Table 1 compares the NHS information materials on the ND opt-out system, highlighting the similarities and differences in the materials provided for different groups. Figure 2 illustrates the opt-out rates, with Type 1 opt-outs reported at the GP level, resulting in potential duplications, whereas Type 2 opt-outs are accurate, with every opt-out choice registered and reported with identifiable patient information. Table 2 provides a comprehensive overview of the opt-out rates in England, with Type 2 opt-outs converted to ND opt-outs in May 2018. The discussion shifts to the concept of paternalism in healthcare, particularly the notion of hard paternalism versus soft paternalism, referencing Cass Sunstein's work, which challenges John Stuart Mill's harm principle. The four types of paternalism are categorized into hard and soft paternalism, differentiated by the imposition of material costs on individuals. The legitimacy of government intervention in individual decision-making is contingent upon conscious awareness and voluntary actions. The bridge exception illustrates this point, where government force is justified to prevent harm when individuals are unaware of risks. Sunstein's libertarian paternalism advocates for designing choice architectures that promote active decision-making, addressing limitations of one-size-fits-all approaches. Behavioral law and economics has gained significance in policymaking, with nudge theory improving the normative framework. However, concerns arise with the UK's new ND opt-out system, which may be seen as hard paternalism, due to limited choices. A soft paternalism approach is advocated, promoting choice while respecting citizen freedom and welfare gains. This approach aligns with active choice mechanisms, nudges, and default rules, emphasizing the importance of revisiting decisions. The Type 1 opt-out system is recommended as a default rule, enabling patients with more options and stronger data protection without overriding individual freedom. The discussion highlights the need for a nuanced approach to government intervention, balancing individual freedom with welfare gains. The research is supported by grants from the Novo Nordisk Foundation and the Multidisciplinary Health Cloud Research Program, citing works on behavioral economics, public responses to health data sharing, and big data in health research. The implementation of suicide risk detection systems on social media platforms raises ethical, legal, and broader implications. The authors emphasize the importance of addressing these issues, ensuring that such systems respect user privacy and comply with relevant laws. The paper discusses the ethical considerations of big data in healthcare, patient consent, and privacy, as well as the legal framework governing health data, focusing on the GDPR. Here is the combined summary. This comprehensive compilation of references traverses the intersections of healthcare, artificial intelligence, law, and behavioral economics, focusing on healthcare data and its secondary use. The cited works underscore the escalating significance of artificial intelligence in healthcare, the challenges inherent in electronic health record data, and the imperative for robust frameworks governing the use of personal data for research purposes. The European Union's General Data Protection Regulation, GDPR, and its research exemption are specifically highlighted. The role of behavioral economics in shaping policy decisions is emphasized, with a focus on nudging and opt-out strategies, as illustrated by the works of Thaler, Sunstein, and others. The compilation delves into the complexities of consent, trust, and public perceptions regarding the use of health data for research, underscoring the need for transparent and ethical approaches to data collection, storage, and analysis. The legal and regulatory frameworks surrounding healthcare data are addressed, with references to various national and international initiatives. The tension between promoting innovation and protecting individual privacy is a recurring theme, highlighting the importance of interdisciplinary collaboration and a nuanced understanding of the technical, ethical, and legal aspects of healthcare data management.